YouTube. That's right, isn't it, Francis? Be on YouTube.
Yeah, that's right.
So we'll find a way of making that available to you. So I will just quickly go through some slides. My objective is really to be having much more of a discussion about this rather than just talking them through, because I'm sure you're all very capable of finding the documents and reading through them for yourself. So I'm just waiting for the right thing to come up for me to be able to share that with you, so I'm not just sharing my PowerPoint screen.
Yeah, I had to manually give you permission, Jackie, so I think you should be able to. Oh, yeah, I can see that. Yeah.
Is it coming through now?
Yeah, I can see it.
Lovely. So hopefully now you can see the PowerPoint and you know that this is going to be about the pressure ulcer consultation. So let me just move the slides on. So I guess you're all very aware of why we're looking at pressure ulcers. They are, as you know, in the top 10 harms reported in the NHS in England. So many of you will be familiar with the incident reporting system that we report pressure ulcers into. And we know that they are one of the most common things that we see within that system of harm. And when we investigate those pressure ulcers, what we do find is that the biggest contributors to the patient developing a pressure ulcer is a variation from what we know is evidence-based practice. And in some ways, we have to take some responsibility for that because we have no standardized pathway for people to follow. Whilst guidelines exist from NICE and from the international community, there is no way of translating that into a very easy to follow clinical pathway. So people develop their own pathways, their own policies and protocols, and because they're locally developed, they can vary substantially. That also means that's a lot of work for each organisation, for each clinician involved, and that the way things are interpreted can also vary considerably. So what we've tried to do is put together something that will be standardised across the whole of England. So the pathway identifies what good looks like, and it's based on a good, strong evidence base. So it's an evidence-involved pathway, and we hope it's what will be adopted across the whole of England. It's based, as I said, on the NICE guidelines, the NICE standards, and also on the international pressure ulcer guidelines, which are produced by the European Pressure Ulcer Advisory Panel, the American and the Pan-Pacific panels as well. NICE guidance was updated in 2014, reviewed in 2018, and the international guidelines in 2019, and they will be due for a review again in 2024. So we're working on the best evidence from those, plus any more up-to-date systematic reviews we know we have from areas such as Cochrane. So both the recommendations and the pathway describe best practice care in all health and social care settings. So that includes hospitals, general practice and community services, as well as care homes and other care providers. So if you're a private provider, whether that's a care home or a private hospital, this will also apply to you. And they're applicable for both physical and mental health care needs. There is no age range to them, so they apply in paediatrics, and they also apply to settings like maternity, and we've been questioned quite a lot about maternity. And they seek to inform and support the care delivered by all health and care professionals caring for any person who may be at risk of pressure ulcers. So this is the document that you'll see if you go onto the link, and the clinical recommendations and the clinical pathway are in both within that same document. The document covers 5 main areas. We look at the identification of somebody at risk of pressure ulcers. We look at risk assessment and diagnosis, ongoing care, review of healing, and care following healing. I'm going to start with the pathway because I think it's quite helpful to have a picture in your mind of what we're doing. And for me, one of the things that's very different about this pathway is the breadth of the pathway. So you will all maybe have in your own organisation something that talks about a patient being admitted and risk assessment occurring and preventative actions going into place, and then incident reporting if the patient develops a pressure ulcer. What's missing from that are the beginnings and ends of this pathway, and I think we've all been very guilty of focusing on the middle. So I'm going to show you each section of the pathway in a little bit more detail because I think it's easier to see if it's a bit bigger, and I think there will be specific areas that I am fairly confident that you will have questions about. So in that first section of identification of someone of risk of pressure ulcers, you can see I've put a box here around this, about what happens outside of healthcare. We've been very guilty of focusing about what happens in the NHS. And by outside of healthcare, I don't necessarily just mean in care settings as well. I mean, we need to think about raising awareness with the general public, because we know coming into the NHS, we have a large percentage of people who are being cared for by their family, by informal carers, whether that's an informal carer that they've paid for through their own personal budget, or however that might be, and developed a pressure ulcer there. And if we want to reduce the total burden of pressure ulcers, we have to look at everywhere that those patients come for. We have, for the first time, made a recommendation about using a standardised screening and risk assessment tool. We have chosen a tool that has a good, strong evidence base. The Purpose T risk assessment tool was generated from the last output of the international guidelines. Started in 2014, came forward in 2019, and has had significant work done to support that. There are real benefits to using the same risk assessment tool across a whole system. It means we're talking the same language. So at the minute, we have some risk assessment tools where the higher the score, the higher the risk, and some where the lower the score, the lower the risk. It means that if you have staff moving across the system, so many of you will be using agency staff, they will be familiar with the tool. And it also means it simplifies things like documentation as we go through. With the Purpose T risk assessment tool, you can see it's very clear, it's colour-based, it's red, amber, green, something that we're very familiar with. And what's really helpful is it identifies very quickly with the screening tool those patients that are not at risk. So some of you will work in areas where a lot of your population are not at risk, but you're driven to do a risk assessment because that's what's mandated to do. And it's very time consuming and it serves a very little benefit. Here you can see that you screen the patient, and if they're not at risk, they don't have 3 of the significant risk factors, then you just document that. We have a second category of no pressure ulcer and at risk, and a third red one that they've already got a pressure ulcer. If they already have a pressure ulcer, I hope you would all agree that almost doing the rest of the risk assessment is not necessary. We know they're at risk, they've got a pressure ulcer. So once you've identified them as being in the amber or red category, so remember, if they're green, the only thing you have to do is document it and set a date for reassessment. If they're amber or red, then you have to think about what care you are going to deliver to them. So if they're in the amber bundle, in the amber box, they have a risk but not a pressure ulcer, then you would deliver the prevention based on the asking bundle, something that we've had in place since 2018, with a really fundamental core of the skin bundle, patient skin assessment, provision of a surface, keeping the patient moving, monitoring increased moisture, particularly incontinence, and looking at the patient's nutrition and hydration, and making sure around that we're focusing on that assessment, reassessment, and the giving of information. Not just to the patient and the family. Remember, giving information is about sharing between the interdisciplinary team, making sure that we all understand what's happening for that patient, and that the patient and their family, where they want to be, can be part of shared care if necessary. If the patient falls into the red category, they already have a pressure ulcer and so are at risk. We then want to make sure that we are focusing on delivering good wound care for that patient. You will all have come across patients in your care who've had a pressure ulcer for quite a long time, whether you mean a month or 6 weeks, or whether you mean a year or 6 years. We know that we in the past have been guilty of not focusing on what happens once the patient has got the pressure ulcer. They get the pressure ulcer, we incident report, we do root cause analysis, and then the patient is lost into the system. With this pathway, with these recommendations, we want to be really sure that what we are doing is making sure that we keep an eye on that, and that we evaluate that on a regular basis. And if our preventative care and our wound care is not making a difference, as you can see in this red box here, that we escalate that and we improve our interventions, we upgrade the systems that we're using, we upgrade the equipment we're using, and that if needs be, we make referrals into more specialist services to get better care delivered. So following on that, we have a review of the risk, we look at the care that's delivered, we look at the status and the healing, because the burden of pressure ulcers is not just about the people who develop a new pressure ulcer. We've been very focused on this incidence. People developing a new pressure ulcer in our care reflects on the quality of care. And that is still really important. We need to prevent what we can. But in terms of the burden of patients with pressure ulcers, probably the bigger part of that burden is the patients who don't progress to healing. So as I mentioned previously, we have a large number of patients using our resources, having a poor experience, experiencing pain, becoming isolated, having very smelly wounds, all those things that you know go alongside pressure ulcers, because we have not focused on, are they healing or not? And I also think it's really important that if you look at this little grouping of things here, we still don't know with any clarity how many of our patients heal in our care, how many patients improve in our care. If you don't have them for long, so if you're in an acute setting, your patient's with you for 2 weeks and they've got a category 2 pressure ulcer, we should be healing that, but in 2 weeks, we should at least be seeing an improvement. We don't have good data to support that. We should also be looking at if they're static or deteriorating, are we taking that seriously? Are we saying, okay, we're giving them preventative care, but their wound's not healing, so should we be stepping that care up? And equally, we don't know how many of those patients die. And we know from kind of local data that the number of patients that are referred to specialist services with category 3 and 4 pressure ulcers, a reasonable percentage of those patients die within 6 months. And we don't know if they die because they got a pressure ulcer and that's hastened their death, or whether they get the pressure ulcer because they're close to death. But at the minute, we have no idea about that. Equally, one of the things that we do know is that the number of patients with category 3 and 4 pressure ulcers, so we're talking about deep wounds here, that get surgery or referral for surgery is very low. And it is even more than postcode lottery. It's very much about if you're in a very specialist service. So if you're a patient who has a spinal injury, the chance of you getting surgery for your category 3 and 4 is far higher than if you're a patient with any other diagnosis at all. So this is what the recommendations look like. And really all I'm showing you here is what underpins that pathway. So the first thing in the recommendation is that immediate response. What should you be doing? And very importantly, it says that whether a person is being seen by somebody from health or social care, there should be an immediate consideration if they have a risk factor. And that you should also respond to a request from that patient or their family or informal carer who's identified a risk. And the red flag risk factors that we're talking about is discoloration or heat or swelling or redness if the skin is light over a bony area or under a medical device, an existing pressure ulcer or a scar from a previous one, and very importantly, that the patient's had a long lie. We know patients with long lies are not always admitted to hospital. We know from the ambulance data that many of them remain in their own home, particularly if they're seen to be in a place of safety like a care home, they'll happily leave them in your care. And that immediate care should be getting the patient off the area. If there's a broken area, using a sterile dressing, making sure that they're on the right equipment and that it's functioning as it should be, taking a photograph of the skin as a good record. And if you feel or your organisation feels that the care is something more than you can provide, or the need to assess is more than you are capable or have the capability to do, escalating that if necessary. So this underpins what I said to you about using Purpose T. So we're saying that everybody should have the Purpose T risk assessment. Within that, there is a requirement to assess the skin. So the skin assessment should be based not just on redness. We've been very focused on looking at red skin, and as we grow to understand much more about different skin tones, we know that skin assessment should be more than what you see, that we should be looking at the skin temperature. Is it hot or cold compared to the surrounding skin? What's the texture like? Is the skin very soft or boggy, or is it hard because it's inflamed? And is the patient reporting pain or discomfort over an area? And often the patient's report of pain or discomfort is the first flag that we see. That if a person's identified as being at risk, and if you haven't got those appropriate skills, that we refer on to somebody who can do that. So once the screening has been carried out, you should do a full risk assessment using Purpose T. that should be done based on the NICE standard, which says that should be done within 6 hours of admission into hospital or a care home, or in community, it should be on the first face-to-face visit. And because of the changes we've seen within COVID, we've included within face-to-face visit things like doing a virtual video consultation, that should be clearly documented and how it was done. Also, based on the standard, we've said that screening and/or risk assessment should be repeated following any change in that patient's condition. And that might be that they move area, so they move from a lower dependency area to a higher dependency area, or it might be that they move place from a hospital to a care home, or a care home to community, or whichever way that works. And that there should also be a regular review. So if your patient is quite stable, you should still regularly be reassessing and documenting that, just in case there are some small changes. And our recommendation that the place you record that risk assessment is in the patient's clinical record. And that's really important in terms of the national surveillance system that we're about to implement, that the clinical care record is where information should be recorded in a clear and thorough way. The next part of the recommendations talks about making a diagnosis, having a primary diagnosis. Are you confident that this is a pressure ulcer and not something else? So we really want to focus on making sure that people aren't recording incontinence-associated dermatitis as pressure ulcers or bruises or anything else. They should be really clear that there is evidence of pressure or shear, that the wound is over a bony prominence, or it's under a device, or you can clearly see a picture of something causing that pressure ulcer. And in a change to what we've done previously, we are recommending that we use categories 1 to 4. And we'll talk about that in a little bit more detail, and I'm sure it's something that you'll have lots of questions about. So you'll notice that we are missing 2 categories. In our previous post-run categories, we also had a category called unstageable, and we had a category of deep tissue injury. What we found, and I'm sure what many of you will see, is there are lots of debate about what unstageable is. So unstageable talks about where the wound bed is not visible due to slough or necrosis. That leads to a lot of interpretation about what slough is, how much slough is present. Can you guesstimate that the depth of the wound, even if there is still slough there? But if you look at the international guidelines that give you the definition of what an unstageable wound is, you will see that it says it must be full thickness skin loss. So you've lost both the epidermis and the dermis. If you look at what the definition of a category 3 pressure ulcer is, that is also that it is full thickness skin loss. So by definition, an unstageable must be at a minimum category 3. We know from looking at the numbers of category 3 and 4 pressure ulcers, the number of pressure ulcers we have that are category 4 are very small. So we've made this change to putting unstageables into category 3 for several reasons. One of them is it's a minimum of a category 3 by definition. We also know about the workload associated with following these unstageables to determine what they become. So the recommendation from the 2018 recommendations document said follow them up, and once you debride them, then allocate whether they're a category 3 or category 4. That's incredibly time consuming. That's a large number of wounds. There's a lot of unstageable pressure ulcers that you are following to see if they become a 3 or 4. And you then have to change it. If you put them as a minimum of 3, and actually once you clean them up, they are a 4, then that's a much smaller number of wounds because we know there aren't many category 4 pressure ulcers. So we're saying record them as being a minimum category 3. The deep tissue injury, again, when we started to track through the system what happens to patients who are recorded as having a deep tissue injury, we know that very few of them actually evolve to be deep tissue damage. So we used to have a category called suspected deep tissue injury, and actually many of those resolved of their own accord with just being observed, having some prevention put in place. They never actually became a broken skin that showed you it was a pressure ulcer. So we know that a large percentage of what we initially think might be a deep tissue injury is actually not a pressure ulcer in the first place, because it resolves without us having to do any intervention. We know there are a small number that will evolve, and you will see that they are full thickness skin loss, as deep tissue injury implies. You then categorise it as the pressure ulcer that it appears to be. So again, that's saving workload in that you're not having to keep changing things. It doesn't mean that you don't follow the patient who has that suspected deep tissue injury. It doesn't mean that you don't put prevention in place, but you only record it as a pressure ulcer once it clearly is a pressure ulcer and not something else. It goes back to that primary diagnosis. Make sure that it is a pressure ulcer before you call it as such. So this is the pathways that I talked about previously, and in the recommendations we have put the guidance about what you do based on these colour categories. So the ongoing care talks about following the asking framework, and you can see it reminds you what the asking framework is. And in the appendices, there's a little bit more detail about what might be underneath there. And there's a reiteration there of the colours. What the recommendations do is tell you what level of care goes for each colour pathway. So as I said, with the green, it's very simple. You document that you've done the risk and when it needs to be done again. And that's all you need to do. If the patient doesn't have a pressure ulcer, but they are at risk, you document it, you plan your regular review, but you then implement the asking bundle and make sure that you're reviewing that as appropriate. You give information to the patient and their carer about their level of risk and what they can do to help with that risk reduction. If the patient already has a pressure ulcer, then obviously you do all the same as you would do for amber. Maybe step up the level of equipment you use, maybe step up the level of repositioning that you do. But if they have got a pressure ulcer, they need to have some wound care, unless it's a category 1 in which it's skin care. And what we're saying here is that there should be some evidence-informed wound care based on what the objective of care would be. And that if the patient has a category 3 or 4, you should think about, is that patient suitable for surgery? So we should really be thinking about how we get these patients with their wounds to heal. And they should have the same kind of wound care as you would be doing for any other wound. So, there are good guidance, there's pathways around lower limb and leg ulcers. This should be the same level of detail that we do for a patient with a pressure ulcer. So they should have a full wound care assessment based on the minimum data set for wounds that's documented in the record. And we should be thinking about those elements that we're recording and tracking. So how we're looking at changes in size, changes in tissue type to demonstrate that there's improvement. And this is the guidance for consideration of category 3 and 4 pressure ulcers being referred for surgical opinion. And this recommendation comes from a large piece of work being done, and a large research project led from Bristol from the SIP study, which says, firstly, you need to think about, does the patient have sufficient skin or tissue for surgical revision? Would the individual consider taking surgery? Some people will refuse surgery. Have you tried all reasonable conservative methods? So this means, have you followed the evidence base? Have you done the right things, the kind of more aggressive things you should be doing, including debridement, considering things like negative pressure, considering larval therapy? Have those all been done? Is the patient fit for surgery? And if you do the surgery, are they motivated and able to adhere to what the recommendations you would give to them to prevent recurrence of that once they've had the surgery? We should be regularly reviewing the healing. This is something that people are maybe struggling with a little bit about, what do we mean by regularly review the effectiveness of the treatment plan? So we're not saying that every single dressing change, you should be doing that full review of their medical history, that full review of all their equipment. At every dressing change, of course, we expect you to think about what's happening in the wound. Do you think it's infected? Is it getting better? Is the exudate level more? But we're saying that a minimum of 4-week intervals, you should do a much better review. You should stop and think, actually, it's been 4 weeks now we've been doing this treatment. Am I achieving the outcomes I was expecting? Has anything changed about the patient? Anything improved? Anything deteriorated? What can we be doing and rethinking about? And certainly by 12 weeks, that should be the full comprehensive assessment, going right back to the beginning, tracking their medical history, tracking what might have changed, and thinking, okay, if we're not seeing the improvement we expected, now's the time to refer on to a specialist clinician or a specialist service who would maybe do something differently. And then finally, if you do get the wound healed, we have a process of care following healing. I'm sure you're all very aware of the fact that once a patient's had a pressure ulcer, even if it's healed, the skin over that area, the scar tissue, is much more vulnerable. And that we don't just say, hooray, your pressure ulcer's healed, we'll take you off all your equipment. We now need to think about that being a lifelong area of risk. So we need to think about a process of evaluation of care based on their level of risk. Now, this is acknowledging that some patients do get a pressure ulcer because of an acute state. So you might have somebody who's involved in a road traffic incident, they get trapped in the vehicle, they get pressure ulcers across their arm where their arm's trapped in the door. And because they're then taken out of the car and out of the door and they are fit and well, they will heal really quickly. So they're not going to be needing a mattress for the rest of their life. But what they're going to need to know is that this skin on their arm where it's trapped on the door will remain very vulnerable. They'll need to think about how they manage that skin. They'll need to think about skin exposure to sun. They'll need to think about keeping it moisturized. And then if you think about that in terms of the more normal patients you have, that elderly patient with comorbidities, you need to think about actually, they may have developed a chest infection or a urinary tract infection, and that's why they got the pressure ulcer. But when they got better, they got more mobile again. And they are now almost back to where they were. So they don't need that prevention that they had when they had the pressure ulcer. But what we do need to think about is any time they start to become unwell again, we need to get that preventative action escalated really quickly. So we need to make sure that we have that patient or that person and their family involved in care, in self-care, in decisions about what their treatment plan might be. And for the person with the pressure ulcer, it's really important that we can demonstrate clearly that we have both discussed the care with them and that we have listened to their wishes for what they want and what they would prefer. So you can download the document and the link to the consultation on this link here. The consultation itself is fairly straightforward. You will be asked some basic demographics about what region you're in and whether you're a nurse. And then for each section of the clinical recommendations, you will see a set of questions that look like this. So they ask you, based on that particular section of the recommendations, do you agree with them and does it adequately cover that area of care? So you can tick that whether you strongly agree or strongly disagree or something in between, and there is a box for you to write any comments. So the reason I'm showing you this page is to say to you that it's very helpful to have the recommendations open next to you. So Francis has put the link, I think, in the questions for you in the chat area. And that's really all that I have to say. So I'm going to stop sharing my screen and I'm happy to take any questions that we might have. So if you want to ask a question, if you can put your hand up, that would be really helpful, and unmute yourself and ask a question. If you're not confident to do that, you can type it in the chat. I've got the chat open. I can see what your questions might be. Are there any questions about the categorisation? Is there anybody that feels that's going to be really complicated? Is there anybody who thinks, thank goodness we're only having 4, that'll make life a lot easier? Anybody want to comment on the use of the Purpose T risk assessment tool? I can see there's something being typed in the chat, so I'll wait for that question to come through. Francis, do you want to, I don't know if you've blocked all the people's cameras. I can only see circles of people. I can't actually see people's faces.
I've enabled the cameras, so people should be able to switch them on if they want to now.
If you want to put your camera on, if you want to speak to me, then that would be lovely. Helen's obviously typing a long message. You can just ask Helen.
Oh, Leanne's got a hand up.
Okay. Who's got a hand up, sorry?
Leanne Dawson.
Leanne, do you want to, I'll come back to you, Helen. I'll just answer this question first.
Hi, thank you. Good afternoon. Well, good morning still, rather, everyone. I'm Leanne. I'm a tissue viability specialist nurse. I was just wanting to ask for further input, if you don't mind, Jackie, under the risk assessment section, where on 2.7, where we say that for those individuals whose condition is stable, review at regular intervals. Regular, how would we be kind of offering guidelines to that as to what we'd include as regular? Would that be weekly, monthly, or?
Yeah, as you know, Leanne, this comes from the NICE quality standard, and
Yeah.
that's always been a query about what we mean by regular. And I kind of think it depends on your care setting. So we know that in care homes where a patient might be very stable, if you're in a residential home, the person is very stable and they do monthly. I would think in an acute setting, by definition, they're in an acute setting because they're less well. I wouldn't want to see less than weekly. And it would be something that would be locally defined. I think that's because of the range of settings. You know, what we would do in mental health wouldn't be the same as what we would do in physical health. That has to be something that we maybe find a little bit more detail about. But for the minute, I would say if it's an acute setting, the minimum would be weekly. If it's in a much longer term care setting, something like residential care or a care home, monthly would probably be absolutely fine. And I think that's what we see happening currently.
That's lovely, thank you. Yeah, because at the moment we currently do our Waterloo risk assessments daily, and we were looking at implementing Purpose T with a weekly review of that, unless condition changes or moving wards or pre-post surgery, that type of thing. So I was just checking that I'm on the right lines.
Yeah, it's about if there's any change. If the patient's condition changes, do it daily. If the patient's very unstable, it should be being done very frequently. But if they're not, then why would you do that? We need to think about what the impact of what we do is. Things have become very ritualistic. We're doing them every day because it's, well, then it's done, it's a tick box. But what difference does that make? What we should be thinking about is what that patient's condition is like. Is it stable? Is it changing? Is their environment changing? Are their risks changing? We don't want to leave it too long because obviously you need to be sure that if you have to go to court, that you can demonstrate that nothing else had changed. But we do need to get more focused on what the process is about rather than just doing the process. Helen, you've asked me about the data set. I mentioned a data set. We are also preparing a national surveillance system that will be being launched quite shortly. We already have the acute surveillance system is up and running. We've piloted it and we've got some fast followers working with it. We've got up to nearly 20 people working with that at the minute, and that sits within the model health system. We know that at the moment the data need considerable work to improve them. It's a piece of quality improvement work. And in terms of community settings, we are a little bit further behind than we are with bedded areas, purely because we started with bedded areas because we knew they would be more straightforward. The plan is that over time that this would include the whole of the system, and what we're looking to do very shortly is look at doing an implementation program across a whole ICS, because we feel it's really important that we can track the patient journey across an ICS, irrespective of the setting they're cared for. At the minute, when we look at numbers of pressure ulcers, we focus on certain things. So I mentioned incidence of pressure ulcers. Do they develop a new pressure ulcer in our care? Is that about the quality of our care? We're also interested in the burden of pressure ulcers, which is more about prevalence. How many patients have we got with pressure ulcers now, today? And where is that care being delivered, and what resource is being used? But also, is that burden growing because we're putting new patients in, the incidence, or is it growing because we're failing to heal the patients with pressure ulcers? So the number that are already in just sit there and don't go away. And unless we can look across a whole patient journey, we will never understand that. And it's really important that the data set allows us to do that. Excuse me. But one of the things that we don't want to do is create more work for clinicians. We don't want to say to them, and you have to fill in another audit and you have to fill in another form. What we want them to be able to do is fill in their clinical record. And that's why I emphasize that the clinical record is the important place where we put this information, and use existing national databases to bring that information through, which is what we are doing. So with the model health system, in bedded areas. The clinician writes in the patient's notes. So we're just talking about the patient's notes, whether they're paper or electronic. Once the patient is discharged, that record goes to a place called coding. Information is pulled from there that's then put into an electronic database. And from that database, it's allowed to pull through into the model health system. In community settings, it's a different database in the middle. So the clinician writes in their electronic patient record, in their paper record, that then is transferred by something called community services dataset through and will be able to be pulled through into the model health system. So the clinician does not need to do anything additional, excuse me, apart from a good clinical record of what they've seen and what they've done. And then we'll be able to track this a little bit more. Are there any more questions? Leanne, a second question.
Yes, thank you very much. It's just regarding categories and deep tissue injury.
Yeah.
Just so I can clarify for myself, although we're not going to be categorising deep tissue injury in relation to it being pressure, let's say I've got somebody that develops a blood-filled blister that currently we'd put an incident form in to say that they've got a deep tissue injury. We document on a wound care plan that we've got a blood-filled blister. We're elevating that and offloading. With this new pathway, how do we still need to incident report that? Oh, because that might just, usually that blood-filled blister would just resolve itself after we've not put any pressure on it for a while. I'm just kind of thinking practicalities of like situations that I see how that would work. I don't want to not, because I've got some form of skin damage, whether it's related to pressure or friction or a bit of perfusion related.
Yeah, so this is separate to your incident reporting system. We are not recommending you change anything that you do in the incident reporting system. The PSERF documents and the PSERF system is recommending that some of the things you will do will be different. So if you are not familiar with it, you'll all be familiar with the old critical incident reporting system. You do an incident report, whether you use Datex, Ulysses, whatever that might be. It gets reported in, and you then have to investigate that. A new system was launched in September 2022 called the Patient Safety Incident Response Framework, PSERF. And that's really encouraging us to think about what we do with those incidents that are reported. So if you take the current system, any patient gets a pressure ulcer, we report it, we then investigate it. We go into quite a lot of detail about why that single patient got that pressure ulcer. If we were to take the factors that made that one patient get a pressure ulcer and change things in the system based on that, might not change anything that would have impacted anybody else, because it might be something really peculiar to that patient. What PSERF is saying is, okay, track your numbers. So let's take category 2s, they're the biggest group of pressure ulcers, and let's look at what's happening with them. So over 6 months, do your number of category 2 pressure ulcers change significantly? And they will go up and down a little bit, but we call that normal variation. You know, in winter you get more than you do in summer because you tend to have sicker patients. But is that what you're expecting? And if it's not changing, then nothing significant is changing either. So what you can do is focus your attention on doing some quality improvement work to reduce the total number of category 2s, rather than just trying to prevent harm to that one patient who got the pressure ulcers. So it's really trying to get us to think differently. So the pathway is also getting us to think a bit more about what we're doing generically, and it ties in nicely with what we're seeing in terms of PSERF. But what you do based on the clinical recommendations and the pathway should not change what you do in terms of incidents. That should change based on PSERF. So the two, although are very close, they're not the same.
Thank you.
And we do, if you want to know more about PSERF, on the National Wound Care Strategy news page, there is a link to a podcast about PSERF and pressure ulcers.
Thank you very much.
Are there any other questions? No questions about using Purpose T? Everybody happy with that? We've had lots of questions about the move over to Purpose T and how you get that in your electronic patient records. We've also had questions about there is a pediatric version, there is a maternity version as well. So if you are looking to use it and have not used it before, you have to go on to the Leeds University website and get permission to download it. By getting permission, you just have to register your organisation as being a user. It's not anything that requires anything specific, and they will give you both access to the tool and access to a package with lots of supporting resources. So there's lots of bits about education, there's some PowerPoints in there, there's some hints and tips on implementation. If you want to implement it into an electronic patient record, we are putting together a small database looking at who's using which electronic patient record. So if you're using System 1 or Rio or whatever it might be, Epic, we do have a list of organisations that are already using Purpose T and using that electronic patient record and have managed to successfully get it in there, because we know that is a challenge to do. So if you want some advice about how to get that in to your EPR, we can probably put you in touch with somebody who's already done it and how they did that. I think for me, one of the key benefits of Purpose T is that it doesn't have numbers. I'm sure those of you who've audited the use of risk assessment tools, the number that get added up incorrectly or sections that get missed is quite high. So with Purpose T, there's no numbers to add up. So it's quite visual. I'll put the link for Leeds and Purpose T in the chat for you for the registration. Just give me a second while I get it up. And that's the link to the page to download your Purpose T if you haven't already done so, to have a look at it. I think there's a real benefit in the screening process. You know, there'll be lots of you in your organisation will have lots of patients who you know are not really at risk. And just by doing the screening tool, you very quickly identify them as not being at risk, but in a formalised and structured way. So rather than just saying, oh, I don't think they're at risk, it gives you a way of documenting that in a way that's been validated. The other really strong thing about Purpose T, I think, is that it asks you for your clinical judgment. So it allows you to override something else by saying, although I didn't tick any of the boxes, actually, in my clinical opinion, this person is at risk. So you can start to build that in there as well. Which I think lots of you would agree that once you've been working with people for a long time, you can start to make those decisions. And the two risks in there, if you're not familiar with Purpose T, the screening tool literally asks you about how mobile the patient is and what their skin looks like. And then in your clinical opinion, what do you think? And if you're saying everything's fine to all of those, then you just make them as not at risk and just review as necessary. Anybody want to ask anything else? Is there anybody from social care or a care home who wants to say anything about this? It'd be interesting to get your perspective on how you think this will work in your setting. I don't want to pick on anybody. I know a couple of the names of people who are here are NHS, people from commercial, but it'd be interesting to hear from the care home setting. If nobody's got any questions, I don't think there's any benefit to keeping you here for 10 minutes more than you need to, just because we said we'd be here till 12. So can I thank you all for your time today? It's been really helpful to have you here. As I said at the beginning, if you ask Frances, she will email the presentation out to you. We will make it available on YouTube at some point, but because we're coming up to an election, we have to be very careful about what things we're promoting. So we do apologise that it's not readily available on the National Wound Care Strategy webpage for you. Make sure you take down the links that are in the chat. That will link you to Purpose Tea, and it'll also link you to the survey. And we would really appreciate it if you do take the time and do the survey for us. But as I said, make sure you have your copy of the recommendations open next to you, because you will be taken through them section by section and asked to comment on them. Thank you very much, everybody.